Okay, hi everyone. We're back again, another teaching session as part of the series that we've been offering in the last couple of weeks. And today we have with us Dr. Mufida Abubakar Sadiq. She will be talking on managing complaints, conflicts, and difficult conversations. And the essence of that is to understand how to build a safer, more resilient workplace in healthcare. This presentation is going to be tailored towards the NHS. Certainly, it can be applied to just about any segment of healthcare anywhere in the world. So, without speaking too much and wasting your time, we'll get to the business of the day. I'll pass the mic now to Dr. Mufida to carry on. Dr. Mufida, please.
Right. Thank you so much, Doctor. Good day, everyone. My name is Mufida Abubakar Sadiq, and like some of us, I recently just got my GMC license. I was opportune to do a clinical attachment, and before that, I had to go through a lot of all these courses that helps you build a safer and more resilient NHS. So among the topics that I had to go through is actually conflict resolution. So when I saw this topic, I realized that I had a little bit of knowledge. And yeah, I spoke to Dr. Jonathan, and he was able to help guide me also. And this is the presentation. So the topic today is managing complaints, conflict, and difficult conversation. This is going to help us build a safer and more resilient workplace in healthcare. So, the objectives of this session, at the end of the session, we are going to be talking about understanding complaints and conflict that arise in a healthcare setting. We're going to recognize the impact of conflict on patient safety and especially on staff well-being. Then we are going to apply practical tools to manage difficult conversations in the workplace and how to respond confidently, professionally, and compassionately when all these issues arise. So, why do we think managing complaints, conflict, and difficult conversation in healthcare matters? Because a healthcare setting is a high pressure setting, meaning emotions are going to be mixed. We are going to have a lot of people from all walks of life dealing with a lot of things, and so we have to really know and learn how to manage conflict. Then there are a lot of complex patient needs and expectations. Like I said, we have a lot of different patients and they have different needs and expectations. So we really have to know how to manage these needs. Then it is a multidisciplinary teamwork, and there would be communication challenges. You are going to also meet a lot of healthcare workers from different departments in healthcare. So you need to learn how to manage difficult conversations with them. And then there is a link between unmanaged conflict and patient safety and staff burnout and litigation. For example, of course, we know in the NHS and all countries abroad, we need to really know how to manage litigation because we might end up losing our license because we don't know how to manage difficult conversations or conflict. So, understanding conflict. Sorry, I lost my slide. All right, thank you. So, starting with the beginning, what is a complaint? It says a complaint is an expression of dissatisfaction about care, about service, or about behavior. So when there is a complaint, it simply just doesn't come from the patient. Dissatisfaction about care can actually come from your colleague, from your junior, from your senior, or from the patient itself. Same with dissatisfaction in service or in behavior. One of the most common causes of complaints in healthcare is communication breakdown. It could be communication breakdown between your senior and a junior in a task. It could be from a doctor to a nurse, from a doctor to a student. A lot of these things happen. It could be delay or unmet expectations. This could be both from your colleagues or from your patients. Then there is perceived lack of empathy or respect. Perceived lack of empathy, especially from the doctor to the patient, or respect. It could also be from the patient to the doctor. Trust me, a lot of these things happen. And we need to know also as healthcare workers how to manage it. Then clinical outcomes versus expectations. We would have a patient come in with something that they think is small, and then you find out that maybe it's a cancer or something very big, and you have to communicate with him, and they might get dissatisfied about what you told them, and they might try to report. We have all gone through that during our preparation of PLAB 2. So I am hoping I'll break it down so that we can explain it better. So responding to complaints effectively. So how do you respond when someone comes and complains about a service, a care that you have given? First, you listen actively and without interruption. Acknowledge this person's emotions and concerns. You need to acknowledge and empathize with them. Even if you are without blame, if it happens with a colleague or another doctor, and a patient walks up to you and tells you that, oh, this is the complaint I'm having, please try and apologize appropriately, even if you're not the person that made the mistake. Then you need to clarify facts and expectations, meaning go back to your notes. Don't just agree and say, oh, yeah, this thing is wrong. Yeah, you were wrong. This is not supposed to happen. No. Sometimes the doctor might be right, but it was the way that he handled it that was not right. So you clarify the facts and the expectations of the patient, and then you explain the next steps. What am I going to do to rectify this? As a doctor, as a team, as a hospital, this is the next steps that we are going to take. After you receive a complaint, please let's try and follow up. Just don't leave the patient and say, oh, since he has complained, I have apologized, then this is okay and done. No, need to follow up with a complaint. Make sure that you have resolved it fully, and make sure that the patient, even after leaving, is satisfied. Like it said, a well handled complaint can restore trust in the healthcare system. So now, let's talk about conflict. Conflict is a disagreement or clash of values, needs, or perspectives. In the healthcare system, common sources of conflict could be role ambiguity, workload pressure, communication styles, then hierarchies and power dynamics. So I was reading something about conflict and this clashes in the workplace. It says that this conflict actually leads to violence in the workplace, and over 1 in 4 people in 2024 in the NHS has actually experienced at least one incident of harassment, bullying, or abuse from either patients, members of the public, or within the healthcare system. So it is very essential that all staffs are actually they feel safe. All staff feel safe while working in the NHS, and the violent behavior has like a very bad effect on staffs in the workplace. So when we are understanding conflict, I have a diagram. I hope it's visible enough. Uh, just
Okay,
so
let me make it larger. Yeah, I think it's
okay,
bigger now. Yeah.
all right. So this is what we call the conflict pyramid. So this is how conflict starts. Let's start from the base. When we are talking about conflict, conflict starts with minor irritations. It doesn't just come at once. It starts with little things that builds up anger and frustration before it becomes a clash. And when there is a clash, then it has escalated. There is going to be a lot of disagreements about those minor irritations. And this clash can actually lead to abuse. And then after this clash happened, the third one, which is the highest, is actually crisis. And when there is crisis, usually there is risk of violence. And I'm talking, it could be assault, it could be verbal, and it could be physical when a crisis happens. So the conflict pyramid, it says conflict occurs at different levels and it requires different response. So using the wrong strategy can actually escalate situations. So using a hammer to crack the knot, that's what we call overreacting to minor conflict. So when there is a knot, maybe just use a tiny stone. You don't have to use a hammer to crack it because it could turn into crisis. So like I said, minor irritations is the low level. It's usually often emotional. It is just a reaction to misunderstandings, and it could be high severity, it could be low severity. So examples could be frustration, irritation, raised voices. So what you're going to do is do not escalate this into formal confrontation. So this is one of the key principles or how to de-escalate the situation. If there is a raised voice, there is little irritations, do not escalate it into formal confrontations. The second is when there is a clash. And in managing a clash, we use something called the Kudsa model. So this is how to de-escalate a clash. Confront the conflict, that's the C. Understand the other person's point of view. So like I said, minor irritations, they cause a clash. A clash is a build-up of all that anger and frustration. And usually when there is a clash, that means you're tired of all the little irritations, and then it leads to a clash. So when there is a clash, the first thing to do is confront the conflict. Then understand the other person's point of view, define the problem early, search for a solution, and agree to a solution that is acceptable to both parties. This is the Kotsa model of managing a clash. So the focus of this is communication, problem solving, and mutual agreement. So two of you have to agree that, oh, this is an acceptable solution. And also two of you have to agree to listen to one another before this can be managed. The last one is what we call the crisis, which is after there is a build-up of a clash, then it becomes a crisis. And crisis is what leads to violence in the workplace. So when there is a crisis, we use the PAMS model. That's position yourself, be aware of escape routes, because like I said, it leads to violence, and violence could be either verbal abuse, it could be either physical abuse. All of this could happen when there is a crisis. So it says position yourself, be aware of escape routes, your attitude, keep it calm and non-inflammatory, look and listen. So you have to, if the person is shouting, screaming, before you know it, someone can raise his hand and slap you. Someone can bring out a weapon. So you have to look and listen, notice small changes that may signal danger. Try and make peace, that's respect the personal space of the person, and also maintain a non-threatening stance. So the focus of managing a crisis, the PAMS model, is safety, de-escalation, and risk awareness. So another type of risk assessment when there is a conflict is nature of the conflict, the severity of the conflict, imminence, frequency of a conflict, duration, and if there is a likelihood that there is going to be harm to others. So there is a video that I want to show. It's called a safer approach. This is how we try to manage when there is a conflict. So please, if you can help me with the video. Thank you.
First, step back, physically if possible, and emotionally. Take a moment to think and assess. The POPs model helps us understand what is happening and identify potential risks and vulnerabilities. POPs considers P, the person or persons involved, O. Any objects present that may help or harm. P. The place, including hazards and routes to safety. S. The situation, for example, any context or background. POPs helps us identify anything that could pose a risk to us or others and influence our decision-making. Find help. Consider calling for help or informing someone early. Don't leave it too late. Evaluate options and consider whether to intervene and deal with the situation yourself, stand back and just observe the situation, hand over to others who may be better placed to help, or withdraw to somewhere safe and call for help. Respond. Having assessed the situation and options available, we're better able to respond in a way that's safe, effective, appropriate and lawful. Remember, continue to monitor the situation as things can change quickly.
Thank you. So moving on, we're talking about the impact of unmanaged conflict in a workplace. If there is any unmanaged conflict ongoing, there is going to be reduced teamwork and collaboration. People will not want to work together because you are having issues with one another. There would be increased stress and absenteeism, poor communication and handovers, increased risk to patient safety, and a toxic workplace culture. So conflict management styles. We have some styles that we advise when you want to manage any conflict. Number one is avoiding. That's either avoiding the situation at all or delaying and withdrawing from the situation itself. Then accommodating, which means prioritizing others, listening to others, giving them a listening ear, or understanding something or trying to understand something from their own point of view. Because sometimes you can't always be right. Maybe they also have something that they want to they want to be listened to. So try and prioritize others and give them a listening ear or understanding things from their own point of view. Then it says competing and asserting control. Sometimes there are people that would just want to bully you, and by the time you assert a little bit of control in the workplace, because there are some people that may be toxic, it would manage some conflict. Then compromising, that's partial solutions. Compromising is almost the same thing as accommodating others. Then collaborating, which is shared problem solving. It also helps. So we are moving on to difficult conversations. It says difficult conversations. What are they? Difficult conversations usually involve strong emotions, sensitive feedback, disagreement or resistance, and power imbalance. So examples in healthcare is addressing unsafe practice, performance concerns, and boundary settings with patients and families. So this could all constitute to difficult conversations in a healthcare setting. So barriers to difficult conversations are usually fear of conflict or escalation, time constraint, lack of confidence or skills, and emotional fatigue. All this could be reasons why people don't want to have difficult conversations with one another in the workplace. So before you start any conversation with someone, if you want to break down a difficult conversation with a colleague or a patient, look at these things and ask yourself, what is the issue and what is the desired outcome after having this conversation? What are the facts and what are the assumptions? What might the other person be feeling? And is it the right time and the right place to have this conversation with this person? So a simple way to have conversations, we also use this framework, which is the LEAP. So first, you listen to the person without interrupting, empathize and acknowledge emotions, ask open and clarifying questions, then plan, which is to agree on what are the next steps to follow if in case there is a problem. Then some de-escalation and communication tips is always stay calm and respectful, use I statements, focus on behavior, not personality, set clear boundaries, and always pause or stop if you realize that the other person's emotions are trying to escalate so that it doesn't lead to a crisis or a clash. So, psychological safety and resilience. Make sure that the staff and people around you feel free to speak up. Always address issues early so that they don't become minor irritations. Learning culture. So always try to learn things from other people's perspective so that you don't end up blaming them for a lot of things happening. Then stronger teams. That means bonding in the workplace and creating stronger teams always lead to safer care. So some key takeaways from this presentation is that violent behaviors can actually have an adverse effect on staff, and some poor communication skills would actually lead to a lot of issues in the workplace. So try and look at your attitude, try and look at your behavior before you talk about, try and, how do I say this? Just make sure that your attitude and your behavior is right before you start a conversation so that you can be able to manage the conflict in the workplace. And like we said, complaints and conflicts are inevitable. So how you respond to them is going to determine the safety and trust that you have in the workplace. And everybody has a role to play to have a safer workplace. Thank you so much for listening to me. And this is the end of my presentation.
Very good. Thanks for such a beautiful presentation. It was very quite resourceful. I think this is one of the areas that probably cause IMGs the most distress in the UK. Because one of the things, and I think I would encourage people listening to, there's a session I did with a lady, very nice, experienced nurse. She does a lot of work with IMGs, Rachel Dexter. And it looks at British culture juxtaposing with various other cultures, because the way British culture is very different. So, and that's very important when you walk, across the UK. So whether it's England, Scotland, Northern Ireland or Wales, the way people communicate is extremely different. So I would encourage people to watch that. Secondly, the way healthcare is, maybe if we go to the very beginning of you, I may give some commentary because we seem to have some time, and this is the area that causes a lot of people problems in the UK. So I'll probably maybe give more commentary than I normally will.
Thank you.
So again, we've discussed you've discussed a lot of the principles around conflict. The main thing I think I want listeners to understand is this is a very important thing that you need to put in your practice. And so that's the very first thing. So I'm trying to, okay, what's happening? Wait, let's try something again. Let me see, because I'm trying to, oh, you shared it, isn't it? Did you mind sharing it again?
No,
don't worry. I think I have it. The problem is it keeps coming from behind, which I don't know. Oh, no, let me see. Which is the first page? This one? No, this is the last
No,
page,
it's
isn't
the
it?
last one. Yeah.
Aha, I think it's working fine now. Yes, so like I was saying, this is a very important area. And certainly you would end up with some conflict. I know people don't like this part of it, but if you certainly come to work, practice in the UK, because I've been here for about half a decade now, you certainly have some conflict for various reasons. Some of it is cultural. Some of it is patients being dissatisfied with their care, which may not necessarily start with you. You know, some of it also may be just the problems of living in a diverse society. But regardless of the circumstance, and then just beyond hospitals, when you may find yourself in conflict when you go to the mall, you know, you go to access a particular service. So nonetheless, this is important. And even in your day-to-day dealings, whether it's with your family members or in your local community, you find the principles here important. So I'll give some context. So like I said, you will encounter conflict in the NHS. So it's important to, one, know that it would happen at some point. Two, to try and understand the pattern of conflict. Yeah, so and conflict could be, like she's rightly said, with colleagues, with patients. In practice, you may find tension between registrars and senior house officers, SHOs and registrars, occasionally registrars and consultants. Yeah, now the main thing to be aware of, because those that are coming new to the UK, it's very important to understand you, to try and do your work the way it's been done in that role over time. So there's a mistake I find people do. Try and understand what is an SHO supposed to do. You know, history taking, line setting, yeah. The next thing is try and also do your role in the given time. Avoid having too much left undone. So one of the things in practice that would help you, because I've been in the UK for a while now, worked several institutions, so many trusts. First, one of the things that would help you not to be able to survive conflict is competence. So the very first thing you want to spend your time understanding is understand the system. So be observant, read, understand dosages, be able to do your tasks as much as you can. So that's on one hand. Understand also the way to both directly deal with conflict and also escalate conflict. So, but these are the common areas you would find is if you're an SHO with the registrar, if you're a registrar with the consultant, the nurses now and then there's differences of understanding, but it also comes down to, you know, you understanding your role competence, so you can easily know what to say to, no to, and what to pass on to a senior. So that's the very first thing. And then, of course, again, competence is important. One of the areas of conflict is you would find patients, certainly they would be irritated. I would be when, for instance, you're supposed to coordinate their blood or book their operations or book their follow-up or explain something or EDSs. You know, so understanding your role, for instance, as a house officer, senior house officer is very important. What do I need to do day to day? Okay, I need to prep the note for consultant ward round. I see the patient, take a history, request investigation. All those things would reduce conflict, or even when they do happen, it's unlikely that they would be deleterious. So that's some of the things to be aware of. Now, understand that just because there is conflict doesn't necessarily mean you're doing something bad, but it's very useful to spend some time and reflect on it. So when they do happen, I think this part I need to go into a bit of detail. So it depends on what type of conflict it is. So in a healthcare setting, in like in an NHS trust, there are a few things to be aware of. So some conflicts are maybe interpersonal or work related. Conflicts that do not involve your professional practice are dealt with differently. Yeah, so things maybe like bullying, things like harassment, conflict that involve patient care are dealt with differently. Yeah, conflict mission. So it's very important to understand this. So understanding the principles of negligence, and one of the key things to be aware of here is, GMC's good medical practice. Now, at the trust level, you want to spend some time and follow as much of your trust guidelines as possible. So in the UK, you won't see, maybe I'll use Nigeria as the example. You can't just come to the hospital and just be prescribing whatever you like without a reason. Most of the trusts, if not all of them, would have some antibiotics guidelines. It's going to save you a lot of headache if some of them have apps. So ELOS, BNF, that tells you, what they use in their own hospital. So it's very important to, secondly, of course, keep up to date, understand the pathways of when a patient comes in ED, what am I supposed to do? Now, in the UK, there's a culture of, how do I say it? Maybe arguing. People argue a lot. People argue their point a lot. Now, that's not to say that doesn't recuse you from doing your work properly. So spend time and say, oh, what are the most common things I see in this role? Pancreatitis, what am I supposed to do as SHO? Acute cholecystitis, what am I supposed to do? Okay, intestinal obstruction, what am I supposed to do? Yeah, you need to try and implement your own part of it. Acute appendicitis, COPD, how do I chase CT? Or when it's during work hours, when it's outside hours. So these things would reduce, the conflicts, the complaints, the problems you would get with patients, with colleagues, and all of those things. So that's important. Now, of course, I won't repeat all of the things you've said. Try to listen, acknowledge the concern, apologize appropriately, and clarify facts and expectations. Again, these models are very important because it tells you the paradigm, or it tells you sort of like the chronology of how things happen until they get to a stage where, they tend to become problematic. And it's very useful to, try and use them to try and contextualize. So if you have a job, you should have an idea. The people you don't need to get along with everyone. You should be able to have an idea of everyone's temperament, and you should be able to function within the team in that context. Now, of course, professionalism and all of that. One of the things I tell people all of the time is be careful of how much of your personal information you share at work, anywhere in the world. Now, while it's appropriate, for instance, if you need to apply for maybe leave or something to share confidential information, it's really important to be aware of the fact that the workplace and your personal life are not the same. Colleagues can be quite friendly. Colleagues, in my opinion, are usually not family members. So I've seen people make these mistakes. They overshare and know that any information you tell a colleague is likely going to go around the building. However, if it's shared confidentially via an email, data protection protects it. At least that's the way the UK works. Other places, maybe not so, but important to have this at the back of your mind. So the models are very important. One, read the room, read the team. I used to teach the principle of 3. So in the UK, I really don't discuss anything much personal, except I've worked with you for at least 3 months or 12 weeks. Then I have an idea. This is just me. Other people, fine. The culture in Britain is everyone is polite. Now, whether they mean it or not is a different conversation. Nobody's going to come out impolite to you. There are a lot of people who are nice. So spend some time to know someone before you begin to discuss too many things personal about yourself, be it family, children, what you want to do next. Yeah, so this again, what I would say is it's good to be able to tolerate, minor irritations. Again, when it's also good to be able to know when I need to formally address something, So when you come into the organization, spend some time really learning about, processes. A bit of boundary, I think, if you work in the West is important. Not just the West, but my principle is nobody has the right to ask me anything personal except I feel like I want to talk about it. Now, some people say, okay, Mr. Aja, Dr. Aja, whatever you call me is maybe a difficult person. But in principle, I think you need to carry yourself in a way. So if I come into an organization, really in the first 3 months, I'm not all over. I mean, I'm happy to have coffee, be respectful, but I spend some time just to feel people's energy. And then, I make, I approach things. There are things, again, that I avoid. I'm not a big fan of, I don't see why I should go to work and start talking about anybody else. The only thing I'm interested in doing when I go to work is the things that move me forward, how I'm going to make myself more money or more. I have no interest in this. However, small talks, they call them, is very popular. What you end up finding is you have so much data about people. I'm not sure what you do with it. I'm not interested in coming to work and knowing really how many times my co-worker has been married or unmarried. I mean, if we become friends, then fine. But one of the things you would find at work is small talks. Are they good? Fine. You can. But if you give yourself some time, you can tell, yes, this is a friend of mine and we can have coffee and, we can. So those things are important to pick up, because IMGs, these are areas, these are the nuances in British society that they struggle with. And like I said, if you go back and watch the video the session I did with Rachel Dexter, she's British, English lady. She goes into depth, and then of course, if appropriate, why not? She does teach a course about the nuances of British culture. Because a lot of people, that's where they find. So I won't go into the models. They talk about the things to do. I think the only thing I would add here is also understand how to escalate in your institution. So oftentimes in the UK, there's a panic button you can press in clinic. So it's usually just under your clinic seat. That's one. And then I'll tell you my trick. So if I think anywhere in the world, I'm a surgeon, so sometimes you have the most difficult conversation anytime you're trying to break bad news or in vascular surgery, when you are trying to explain that there's no more revascularization option and we're heading towards amputation, is not really, it can go very problematic. Now, I can share my experience, tends to be, I'm not promoting race or ethnicity, it tends to be, so the way minority ethnic groups accept dying and death is different from the majority ethnic group. So in my experience, our own people, and then of course the other BAME, they are not easily accepting of death, dying, amputation. Not that it's a bad thing, it's something to put in context. Yeah. So you may end up having, so we tend to, in my opinion, I've done this like significant trust. So you need to really be patient. So don't think, oh, when you come, you do the first meeting, they would accept. No. Yeah. So you may do several more meetings. Where appropriate, clinically appropriate, you may do procedures that are maybe 50-50. Is a little bit different with the other group. So the relation or the understanding of, death and dying is slightly different in my experience when you look at, and that's probably from culture, from religion. So the perception and the concept of death is different. So when you, I have counseled patients on this, like maybe hundreds now. Nigerians, Indians, Pakistani, Muslims, Christians, white, Spanish, is a little bit different. Yeah. So with some groups, you have to make that allowance in your mind, knowing that you may need to do more meetings. Now, in practice, what I do, if you can, and is recommended, go with one of the senior nurses. Some places they have the breaking bad news cancer CNSs, which helps, and then sometimes you have to do multiple meetings. Sometimes you need to involve palliative care. So these, of course, we can't explain all but these are some of the things to be aware of. The cultural groups react or understand and accept different when there's no options for treatment slightly differently. Now, even within the UK, the more suburban and urban, so it's slightly different in London, so in London, they would be more, their expectation is a bit, I think there's probably something more. In suburban, maybe a bit slightly. So those are just some of the things when you go into difficult conversations with patients. And certainly where you can, get a senior, again, knowledge, as you become more experienced, it becomes easier. So no need to talk too much about these models. Yeah, so when conflict does occur, there are a few things that you need to I recommend that everyone does. I think having a recognized union is important. So you probably need 3 unions, or I think 2. One, you need an indemnity insurer. So there are basically 3 of them. because sometimes, regardless of your effort, things can really go quickly turn into a medical negligence situation. So you can either join the MPS, Medical Protection Society, or you join the Medical Defense Union. These are the main ones. Or you join the MDDUS, Medical and Dental Defense Union Society or something. The main difference is the cost. They cover by and large the same thing. So this is important if you run into any medical negligence situation, because they would help come to your trust meetings. And if there's the unfortunate situation of a GMC referral, they will also support that. The BMA, which is the British Medical Association, I mean, it's been quite controversial. I'm not formally a member anymore. I'm a member of the Health HCSA because I don't think the BMA really represents the interests of IMGs anymore. And I think that's the truth. They know this. I know this as well. So, but the BMA is going to help you with almost every aspect of, coping with the system in the UK outside a clinical negligence situation. So if, let's say, you and your consultant disagree, if there's a pay dispute, if you think there's promotion issues, everything that has to do, nothing to do with patients. So the BMA. The other union, not as large as the BMA, is the HCSA, which I belong to now, do the same thing for you. Probably a bit better because they are a smaller team and they have a national advisor who comes to your hearing. There's different, someone said, you were in a locker, you were in maybe the mess with them, and you looked at them in a seductive way. There's no video, they've reported that, that kind of stuff. So that does happen. Now, what would be the reason for that? It's difficult to say. But again, this kind of stuff, the BMA, the HCSA would help with that. For instance, you're employed as a registrar, then some consultant thinks without discussion with you, you should be demoted to an SHO. In their own opinion, they had a meeting with you where there was no minutes or whatever, and they think you've agreed, and then, the HCSA, the BMA, these things can happen. Now, there are sometimes really genuine reasons why these things are needed. You're not used to, there's an agreement of induction in your contract and it wasn't delivered. But the reason I formed this group is so you have an idea of these things before you start. So again, the BMA, the HCSA would help you with this. The BMA, of course, certainly has resources around induction, cultural induction, trust induction. Some trusts have their own processes. You think you should have an educational and clinical supervisor. However, none has been given to you. You've raised it up. You were promised verbally a renewal. Now they said no renewal. So all these things, are things that the BMA HCSA can help you. Now, there are other, maybe not so much of, let me just take a minute and put the survey link. Please do the feedback link, please. So there are other unions that people also get to join. So if you're a Nigerian, Mansag is one of them. If you are of Indian origin, BAPIO, So you have Sudanese, Kenya, and then sometimes you affiliate. They're also useful for presentations and all of those, and they can help with disputes and conflicts. So, so those are some of the, I think, most important. These are the important, some of the important bodies you would need. But beyond that, it's important to also, you know, get along with people as much as you can. Do your job as competent as you can. So it's worthwhile to spend time, you know, working on your competence as you come into the society. Also spend time understanding just, you know, the guidelines, the rules, and all of that. So I think, so I've talked about, so I think in terms of conflict, yes. Now and then you can, of course, involve, so if you are training, it's slightly different. Or no, in practice, if a conflict were to happen, so if a patient incident does happen, so follow the principle of your trust guidelines. Usually, I mean, if it's in a real time, what you want to do is you want to do everything to make sure the patient is safe. So let's say you're putting a line. You're attempting to put a peripheral line in a vein. Let's say you're trying to set line in the hand and you think you've gone into the artery. So the first thing to do is to stop that procedure, you know, and take out the line and put some pressure. Yeah. Now let's say that in a patient that is hypertensive and has coagulopathies. So you may want to ask, is it appropriate? I need to let my senior know. Typically, you want to tell your registrar, or you inform your consultant or your clinical or educational supervisor. So when something serious has happened, it's good practice to discuss it with, if you are a trainee, to discuss it with your educational or clinical supervisor. Yeah. Now, there are some instances where you need to update it in your training reflection when it's appropriate. So those are some of the things to be aware of. Now, complaints usually, when it involves patients, will go through something called PALS, except, of course, it's exceptional. So in the few instances where maybe something is harassment, battery, or bodily harm, then the police may be involved. Or again, sexual harassment, police may be involved. But if it's more or less straightforward, it will go through the patient liaison service called PALS. So PALS will have an interaction with the patient. The patient will give them an account, what they are unhappy with, and then PALS will engage the service. And then, you know, you take it from there. So I'm just trying to give the, you know, the real, like how this works, like in an NHS setting. Rarely, if something really bad happens, then they may take the doctor out of clinical work, and then they would try and do a hearing. So it's important when you come in, I've explained these things, you know, try and get a defense union, be part of the BMA. You can always ask them for guidance if things are, you know, something serious does happen. Yes, so again, one of the things that causes issues with conflict is communication. And there are many models. And one of the models that I have created for handovers is Hive. And I've done a video. It's important to learn, you know, how to do handovers properly. So Hive is a very useful model. and I think I've done 2 videos to explain this area of, how to discuss, with a senior. Always realize that you probably need to do 3 things. When you want to discuss with a senior, what are you calling them about? What is the question? What information do they need to advise you? That's it. In reality, nobody's interested in how long you've been in the hospital, a long-winded history. Nah. The expectation is, if I'm calling a consultant and I want to do an operation on my own, I want to tell him the reason, I want to tell him the distance, I want to tell him the form of anesthesia, I want to tell him what I want to do. I want to say, maybe ask him, should I do an interposition graft or should I do this other option? I'm considering this one for this reason. This is what I've seen in the CT. This is what the bloods look like. If I want to decide stoma or no stoma, what is the albumin? So you want to be as concise as possible. So these are some of the things around communication. So do watch the video on Hive, where I went into some detail, because handovers are very important, and understand the handover structure in the UK. And I've explained it in the Hive video. So there's something called the take team, the post-take team, and the on-call team. The take team and the on-call team are roughly the same. So they are the first people that have seen the patient. The patient might not have been physically reviewed by a consultant. So when that does happen, that's like the post-take. Then the patient goes to formally be under a consultant. That's roughly what you would see in internal medicine and surgery and gynae and the rest. So these are, again, ways to resolve conflict, when the need arises. So I think, again, as you become more informed, about the system, I've talked about competence, I've talked about a lot of the societies and associations that would help you, from the formal ones within your trust. So within your trust is key: your clinical supervisor, your educational supervisor, the service lead. Now and then, the service managers are also involved if it matters. Then, of course, BMA, HCSA, MDU, MPS, or MDDUS, depending on the one you belong to. Sometimes MANSAG or BAPIO. Now, it's disturbing. I've seen people, IMGs, they will come to the UK, they don't belong to any association. Let me just warn you, if you get into trouble, you are going to be roasted. The rules are just too many. Yeah, it's different. So you wouldn't know your right. You wouldn't know what to say, what not to say. You have no idea. So coming to work in the UK and not being part of a union, if you are not a British person, I just think is suicide waiting to happen. This is my opinion. Now, if you've lived in the UK a long time and you know your way around, HR, that's a different conversation. But I think it's just in your best interest to just pay the £20 or whatever pounds per month to BMA. And then, in case you need them, at least, then once you know your way around, fine, you can. And then MDU, important, because some of the issues you may run into, you have no control over. You may be exhausted and, something will happen and, medical negligent case may be raised against you. So we've also talked about a lot of things. So I think at this juncture, let's see if there are any questions. Oh, whoa, okay. Click. No, people have been using the, what's happening? Oh, what did I do? Sorry, I think I gave them the wrong link. Sorry, guys.
I think you posted the link for the live instead of the
Yeah, yeah. Okay, let's. Sorry, guys. Let's do that. Okay. Okay. Yeah, so any questions at this point? Mufida, back to you. I think, excuse me, I've added the 2 cents that I think.
the 100 cents. Thank you so much for if there are any questions, please, you can just write it on the chat box so we can answer. Thank you. I think one thing that I wanted to also ask you, Dr. Jonathan, a question is about the reporting when there is like a clash or crisis. Yeah. So how do you report within the healthcare system?
So it depends on what's the extent, but generally UK wide, there's something called incident reporting.
Yeah.
You may hear some people call it an IR1 or day texting. And sometimes people would say, this is a day text, I'll day text you. So if you have anything that you're concerned that put patient at risk, or a certain behavior that you think is highly concerning to you, then of course you put in a day text. Usually you put you put one through the intranet. So usually in your induction, we may do a session, or I may share some resources of how the process of day texting. I think I should. Incident reporting and day texting work. So that would be the case. Sometimes it's not a day text, even though I think in practice people abuse the day text in a little bit. Yeah, so a bit too much. Sometimes, of course, if you think someone, so because I came from a university point of view, so if I think, I think this staff is crossing the line a little too much, yeah, you can do like a one-to-one email with them. I don't tend to do that. I tend to do an email with a third party appropriate. So like a senior manager. That is like, listen, like I don't like this. You just raise it and say, like in a very professional way. So that's one way to deal with it. And then sometimes you can have, if you think it's appropriate, you can have a word with the person. So it all depends on, how you feel. One of the drawbacks of having a direct word is people would deny, people would argue, people would try and turn it around. So it's not my most favorite. Like if I think something is a little crossing the line are more likely to use an email.
Okay.
But again, it all depends on if you manage yourself properly at work. But that's so if it's like if you are worried, you are on call, there is not enough staff, you can put an incident report for patient safety. Patient threaten you, your colleague threaten you, you put in, and then you put in the department, and that's investigated. It has to be investigated and closed. Sometimes if someone maybe is doing something that is borderline, you may address them through an email. You get me? Sometimes you can, of course, also complain to their manager. So let's say the particular nurse that is making your work very difficult. So fine, you can complain to your senior or the nurse in charge and say, it all depends on the circumstance, but these are some of the options.
Thank you. You have a question?
Someone was asking, yeah. Mention the defense union. The defense union is MDU, that's the Medical Defense Union, the one for negligence. Then you have the Medical Protection Society, and then you have the MDDUS, which is, I think, Medical and Dental Defense Union of Scotland also. Any of these three should be fine. It's good to have it because when you have an issue with medical negligence case, they don't tend to accept you if you join after you had the case, and it may not cover you. So that's the problem. So if you were to be sued and you lose, and let's say a judge awards the patient compensation, it will depend. If it's done on the NHS premises, ordinarily the NHS premises insurance should cover you. If it's outside your usual NHS work, maybe you went to do locum somewhere, it may not cover you. So if they were awarded, for instance, £1 million, that means you are going to be bankrupt. So legally, the court can take everything you own. Now think about it this way. If you have a mortgage, the mortgage has gone. If you have shares has gone. Yeah, so that's the for other things like I explained, BMA, HCSA are the go-to. Mansard can help you, but they are not like formally recognized as a trade union. Unduk even can help you. Bapio can help you. Sudanese, all of them can be involved, but the ones that have the main network are these Medical Defense Union and BMA and HCSA. Those are the generally the ones if you work in healthcare. Now, if you work in what is it called? If you work as a doctor. If you work in academia, you have UCU, which is University and College Union. So that's the one for academics, because I've done both. So I've been member. There was a time I was even member on both. I think I still am. So they can defend you for academic. They can do a bit of crossover when necessary, but and then in other roles. Now, you don't necessarily, so sometimes there are other, what's this one? There's Unite and Unison. Even as a doctor, you can join Unite or Unison. So it's not, being part of BMA is not like a must. So you can join Unite or Unison as a doctor if you want to. It's just that BMA is because it's run by doctors. Unite and Unison will defend you as well. They will follow you to your meeting. They will do everything. So some doctors that maybe started at HCA or something, yeah, you keep your Unite is enough. They'll get involved in whatever negotiation you need. So this a bit of the, hopefully nobody needs it, but I think we've had a decent coverage of the key ones. Okay, any other question? As we round up, we've gone slightly over time. And do please remember to share the feedback and also, share this forum with as many of your contacts as possible. The more, the merrier. Okay, so Mufida, any other? I think I would allow you round up while we close.
All right. Thank you so much for the wonderful additions to the presentation. One thing that I just want to add is that it was a really insightful presentation because we got to hear a lot from you. And what we got to hear is actually your own experience and your own ways of how you have managed conflict, even using some of the models and your own models too, which we really appreciate. So I wanted to ask if in the next coming presentations too, if you have something more to share, if we can like have a session so that
Okay.
you share more. I think hearing your experience also makes it better so that we know that, oh, these things are really happening and these are the ways that you managed it in your own way so that it helps us better so that we start thinking of how to manage. We pray we don't get into the problems, but we also want to manage like our conversations so that and our attitude so that it doesn't lead to conflict and everything.
Sure. I think
Insight.
that I'll see as much as I can be involved. I just try to, allow the presenters, take most of. I'll do put as much input as I can. Okay. So at this juncture, I would like to thank everyone for, tuning in and staying with us. And please do share amongst your network, so we have the more the merrier. So we have more people giving feedback, more people watching, more people listening, more people telling us what to improve, what works, what doesn't. At this junction, I would like to thank everyone for staying with us, and we're going to end the live stream in 3, 2, 1, 0. Okay.